I had to line the camera up with the I'm not just clapping for no reason. No, now you're going to screw up my, I'm trying to line the audio with the video, so I just need one
slow
clap.
clapping for you.
Okay, let's clap together. Ready? Just one big clap. Ready? 1, 2, 3. Welcome back to Trauma-ing. We are your co-hosts, James Gould and
Rob Green, the old man.
And we're going to be trying out a new segment today. These are called Rapid Infusers. And the idea here is that we're going to give brief 5, max 10-minute reviews on some pretty high-yield trauma-related topics. And today we're going to be very appropriately talking about rapid infusers. So rapid infusers, we're going to focus mostly on the Belmont and Level 1 infuser, but these are devices designed to deliver large volumes of warmed blood products or fluids quickly, which is essential, obviously, in hemorrhagic shock and major trauma resuscitation. So in terms of what we use here clinically, we have the Belmont rapid infuser. So what the Belmont is a high-speed roller pump with a heat exchanger, and it delivers fluids, warm fluids rapidly with flow rates up to 500 to 750 mils a minute, depending on how big depending on how big the catheter size is. Yeah, so you can put a unit of blood, or 2 units of blood in basically a minute.
How many mils is a unit of blood, James?
So around 250.
250,
300. Yeah.
Yeah.
These are compact, easy to prime units. If you go to our Trauma-ing YouTube page and subscribe, you can watch our model Nurse Brad, priming a Belmont rapid infuser. The other rapid infuser that we've had before and used and have some experience with is the Level 1 rapid infuser. I think probably the other common rapid infuser probably used by the listeners. This uses a different method, so it's compressed air to push blood through a heat exchanger. It can reach similar flow rates. It's cited up to 1,000 mils a minute if there's large bore access obtained. So we have another video. Again, our model Brad has demonstrated how you appropriately prime a Level 1 rapid infuser. And so check that out on the YouTube, Trauma-ing YouTube page, and subscribe. Rob, what can go through a rapid infuser?
Well, usually in a trauma resuscitation, we think about crystalloids and packed cells. So both of those can go through there, and plasma as well, but not platelets, James. Do you know why that is?
Yeah, it breaks the platelets down and makes them not effective, as I understand it. Is that correct?
As far as I know.
Yeah.
I don't know
Perfect
how
science.
well that's been. Things that you should probably avoid is calcium, to be honest. And to be honest, that's your rapid infuser is not where you want to administer medications or anything like calcium that should have an immediate effect, because that's a real rapid infusion of any medications. That if you're say if you get 500 mils a minute, that's going to go straight in and be circulated very quickly.
And these lines we want to preserve for that there's no precipitation within the lines and that kind of thing. So there's always that risk with medications and calcium.
Yeah.
The one of the really important point of these is that they warm the fluid. So as we've always talked about, hypothermia is a significant problem in bleeding trauma patients, and so we want to make sure that fluid is warmed, which these rapid infusers will do for us. Let's talk about some clinical pearls with rapid infusers. The first one I think that's really important is that what we want to always use is wide, large bore access. Ideally, we'd get something like a 16 gauge peripheral IV in the antecubital fossas, but you can use things like cordis or percutaneous sheath is probably the more appropriate name, or a trauma line, something that's basically short and fat, right?
Yeah. What's more important, shorter or fatter?
Oh, gosh. Wow.
What's the law?
Oh, Boyle's law. No.
The Titans.
Charles' law.
Poussey.
Rob Green's law.
So basically, it is the radius of your catheter that's more important than the length. But short and fat is what you want.
Mm-hmm. Oh, interesting. I didn't realize that. So Obviously a percutaneous sheath is quite long, but yeah, it's a large, somewhere between 7 and 9 French in size, so that's optimal. We probably lean, I think, heaviest on the large bore peripheral IVs here in our institution in an AC, just in terms of like the ease of obtaining it and how quick our nurses can get those in, or paramedics can get those in. So
Absolutely, yeah.
The other, just as a pearl, important thing I think to note on these is that, oftentimes when we put in peripheral IVs, we put these little microclaves on. You've probably seen them before, or the listeners have definitely seen and used them before, but they basically are like the lock that goes on the IV. When you put that on, it actually slows some of the flow down. So an important point that we try to always tell our team members when they're inserting IVs is that you want the rapid infuser to be hooked up directly to the peripheral IV and not actually use that little clave or whatever you want to call them.
Yeah. And that's important, right? Like both of these, the level 1 and the Belmont, are very high pressure circuits. And when we just talked about the size of your IV, that's a resistance factor to getting fluid into that patient. Anything that's interrupting that line from the unit to the IV is just more resistance that you're trying to avoid with these big machines.
Yeah. What are some other pearls, Rob?
I think one of the biggest ones for me in the chaos of a trauma situation is knowing exactly how much fluid you're going in, that you're infusing to patients. In my experience with the Belmont mostly is that you can put so much fluid into a patient so quickly that it's kind of too much. Right. It's very easy to over-resuscitate patients, and we don't want to over-resuscitate patients because it causes problems down the line. And so in my world, James, and I'm sure you're like this, you really need to dedicate someone to being in charge of the fluid that's going in the patient and taking charge of the level 1 and or Belmont. Okay, I want a leader into this patient right now. No more goes in until you check back with me. And they're not only responsible for the fluid that's going in, but they're also watching the IV insertion site, because we all see IVs that go interstitial. If you have an interstitial IV on something that's such high pressure as a Belmont or level 1 infuser, then that's a liter of fluid in someone's arm right away, which will certainly cause a problem that your patient should not have to endure.
Yeah, that's right. And they're not getting the fluid that they need, the volume that they need if they need it at that moment.
Yeah.
So, I don't know what the backups are like on the Belmont, and there's pressure alarms and things like that. But the sentiment remains is that whoever's managing that needs to know what is happening at the level of the patient as well. Is the fluid going in? Is the IV still, appropriate and functioning? And we need to have one person dedicated to that. It's a lot of work, right? Like having, we dedicate basically in our trauma resuscitations one nurse to doing this. And basically your job is just the rapid infuser. And we have anesthesia there too, who obviously has a lot of experience with this kind of thing. So if they don't have another task, such as airway management that they have to be engaged in, then it's nice to have them there too to help, participate in delivering massive hemorrhage protocol through our rapid infusers. Totally.
You can put any fluid through there too, right, James?
Yeah. Oh yeah. Yeah. Any fluid can go through rapid infuser. Blood products we talked about, packed red blood cells, plasma, crystalloids, just not platelets.
Yeah.
Some things that you need to make sure you're monitoring when you're doing massive hemorrhage protocol is, the calcium, how much volume you're giving, and the patient's temperature. We're warming these fluids, but anytime you're giving patient high volume resuscitation, you need to make sure that you're not causing harm with some of these stuff. Rob, you already talked about over resuscitation in terms of the volume administered, but there's other things like hypocalcemia as a result of the citrate that's in our blood products. Electrolyte disturbances and the patient's temperature. So keep an eye on those things too.
We here in our center practice on the Belmont and the level 1 of every morning when we kind of huddle up with our emerge colleagues. We actually ask the question of, is everything primed?
Yeah, that's right.
Is the level 1 primed? If not, when was it last done and can we do it right now? Same with the Belmont. And so we make sure that the nurses who we work with, who are the experts in these, actually have hands-on experience in a non-crisis situation, so that they know how to run these during the crisis. And I think that's been a really, really big thing that we've done.
That's right. I think it is important to have these pre-primed as well. And we've had lots of discussions about this, the whether or not it's of value to have these things pre-prepared versus, doing it in the moment. And as you said, we keep them pre-primed with crystalloid. I think it's really important to have at least one of these pre-primed in the department. Yes, it may only take a minute or 2 minutes. These are set up to be able to do quickly, but that is a minute or 2 minutes that you take someone out of the game to do. And we often have that amount of time before the patient arrives. So if they're sick, yeah, sure, that nurse can get that prime before the patient gets there. But that's not the point. The point is that is still 2 minutes that particular nurse could be doing something else. And that something else might even just be paying attention to the pre-brief and having a better understanding of what is going to happen. There's no point in not preparing the things that we can prepare before, the chaos begins and that kind of thing, right? So,
yeah, I think every emergency department who's looking after trauma patients should have not only access to this device that's kept in the emerge, but also a good working knowledge of how to prime it, how to use it, and consider keeping it pre-primed.
Yeah. All right. And on that note, check out, again, our YouTube page where guys can learn how to prime these things and how to better care for your trauma patients.
Boom.
Boom, baby.